Good evening, everyone. And as we always say, compliments of the new year. I'm just going to give us a couple of minutes to allow everyone to join in. Just an apologies from our side for just letting you in late. Just still, as we know, first of the year, dealing with a couple of gremlins with the presentation, but we're good to go now. So I'm just going to give us a couple of more minutes just to let everybody in. And it's great to see all of you back this year in 2025. And just a fantastic welcome to everyone joining us for the first time. It's good to see some familiar names, and we'll be ready to go. So actually, let us kick us off. My name, for those of you who are new here, my name is Dr. Marisha Mahlangu, also known as Dr. Mo, and I am the Chief Medical Officer of Clinix Health Group. And once again, I'd like to welcome everybody to the very first webinar of 2025 and compliments of the new year. Today, speaking, we'll have Dr. Klaas, and he's going to be speaking on quite an interesting topic today, which is periviable birth. So he is a subspecialist neonatologist based in Dr. S.K. Mateka Memorial Hospital and Netcare Alberton Hospital. He completed his BSc Medical Laboratory Services degree at the University of the North. He then furthered his undergraduate studies at Wits, where he completed his MBBCH in 2005. He did his internship in community service at Chris Hani Baragwanath Academic Hospital, and during his community service, he did a diploma in child health. He joined the registrar training program in the Wits circuit in 2008 and qualified as a specialist pediatrician in 2012. He's worked at the Far East Rand Hospital as the head of the neonatal unit, and then he returned back to Chris Hani Baragwanath in 2013. And he joined the fellowship program in neonatology, and he is qualified as a subspecialist in 2015. He then joined Dr. S.K. Mateka Memorial Hospital in 2014 and Alberton in 2015. And today, once again, we welcome him to our platform where he will be speaking about periviable birth. Now over to you, Dr. Mnisi, and thank you. Doc, I think if you can just unmute yourself, please. Oh, let's try that again. Just unmute yourself.
Okay.
There we are. Thank you.
Okay. Good evening, everyone, and thanks, Dr. Mo, for the introduction, and thanks to everyone for joining us. I'm talking about one of the contentious issues in neonatology, that is survival at borderlines of viability, or other people call it periviable birth. Why is the slide not going? Okay. This is an executive summary. It was published in Journal of Perinatology in 2014. A summary from the American Academy of Pediatrics and the College of Obstetrics and Gynecology and the Society of Maternal and Fetal Medicine. I'm just going to read it for you. It's an executive summary of a workshop on the management and counseling issues of women anticipated to deliver at the periviable gestation, which is broadly defined as pregnancies between 20 weeks and 25 weeks and 6 days. And they looked at the treatment options for the newborn. And upon review of the available literature, the workshop panel noted that the rates of neonatal survival and neurodevelopmental disabilities among the survivors, they vary greatly across the periviable gestations and are significantly influenced by obstetric and neonatal management practices. That includes use of antenatal steroids, tocolytic agents, antibiotic administration, cesarean deliveries, and local protocols for perinatal care. and neonatal resuscitation intensive care support. And these are in turn influenced by the variations in local and regional definitions of limit of viability. And because of the complexities in making difficult management decisions, obstetric and neonatal teams should confer prior to meeting with the family where feasible. And family counseling should be coordinated with the goal of creating mutual trust, respect, and understanding, and should incorporate evidence-based counseling methods. And since clinical circumstances can change rapidly with increasing gestational age, it's recommended that counseling should include discussion of the benefits and risks of various maternal and neonatal interventions at the time of counseling. And there should be a plan for follow-up counseling by both obstetricians and the pediatrician or neonatologist involved as circumstances evolve. And the panel also proposed that there should be a research agenda and recommended developing educational curricula on the care and counseling of families facing the birth of a periviable infant. So generally in South Africa, I think even to date, viability is considered as 28 weeks, and these are babies who are around a kilo plus. We tend to see a lot of these babies who are in this borderline of viability, mainly in private practice, because fortunately in the state facilities, there is guidelines in terms of what is a cutoff. And in private, we work a little bit different. We seem to be doing things on our own without guidelines. If you look at what they do in developed countries, like on this slide, it says babies born at threshold of viability create a wide range of polarized opinions regarding decisions about their care and management. And if you look at the US, Australia, UK, Canada, currently the recommendations is that babies born at around 24 weeks of gestation should normally receive active intervention, while babies born at 23 weeks of gestation or less should be discussed with the parents regarding whether such intervention is appropriate. That's what is currently practiced in the developed nations. Locally, I don't know where we stand, to be honest with you. On this slide, the suggestion is that if we look only at survival data, the feeling is that such judgments are intensely personal and highly individualistic, and they are necessarily subjective and not scientific in nature. So as such, if you've got parents, a family that is facing this difficult period during the gestation, broadly between 22 and 25 weeks and 6 days, the people are suggesting that the assessment really shouldn't belong to us as physicians, but to the parents. They should be the ones who are counseled and decide as to what we need to do. If you look at these bar charts, it shows data from 1996 to 2005, looking at 22 weeks, 23, 24, and 25 weeks of gestation. If you look at the babies who are born at 22 weeks, and looking at survival, death after admission, stillbirth, and death before admission, in 1996 to 2005, looking at 22 weeks, you can see that really no baby survived during that period. Around the same time, if you look at 23 weeks, the survival was quite small in terms of percentages. At 24 weeks, you can see from 24 weeks, there's improvement in terms of survival. At 25 weeks, almost close to 50% chance of survival around this period. And this is another slide also looking at survival at 22 weeks, 23 weeks, 24, and 25 weeks. And this gives data from 1991 to 2010. If you look at the babies at 22 weeks of gestation from 1991 to 2010, you can see that there was zero chance of survival. And at 23 weeks, from 1991 to 2010, I think there's a slide of study done in UK, you can see the chance of survival if you look at the percentages. The highest was 20% at 23 weeks, from 1991 to 2010. At 24 weeks of gestation, looking at the chance of survival, you can see the highest chance of survival there in terms of percentage went to up like 43%. Your 25 weekers from 1991 to 2010, you can see the chance of survival improved to 61.5%. So you can see that as the weeks progresses, the chance of survival in these babies increase. This is data that was taken from an article published by the author Wood et al. And also from National Institute of Child Health and Human Development, looking at the gestation as well. And you can see, if you look at the gestation at 23 weeks, according to Wood et al., the chance of survival was quite small. And the data from National Institute of Child Health and Human Development, there was 30% chance of survival at around 23 weeks, 26% according to Wood et al., 52% at 24 weeks, and at 25 weeks, the chance of survival, you can see it's around 54%. And from the data by NICHD was around 76%. They also looked at disability because the concern in these babies who are born at borderlines of viability, the biggest concern is disability. I can see that at 23 weeks, the chance of moderate to severe disability was quite high, 50%, at 24 weeks, 53%, and at 25 weeks was around 46%. If you look at these babies in terms of weight, remember your 400 grammars, these are babies who are born around 22 weeks. At 500, you're looking at your 23 weekers. Your 600 grammars is your 25 weekers. And if you look at moderate to severe disability, they had no data there at 400 to 500 because I'm sure a lot of those babies didn't survive. Between your 500 and 600 grammars, your moderate to severe disability was around 29%. And your 600, your 700 grammars, these are babies who are born around 25 weeks. And your 800 grammars, on average, these are babies at around 26 weeks. So you can see that according to National Institute of Child Health and Human Development, between your 400 and 500 grammars, your chance of survival was around 11%. Between your 500 and 600 grammars, 27%, 63% between on your 600 and 700 grammars, and 700 and 800, 74%. And these are the mobilities. They did this study and looked at your babies who were born less than 750 grams. You look at your hyaline membrane disease, the frequency was quite high at 78%, and babies who are oxygen dependent by 28 days, this was around 81%. Because you struggle with these babies in terms of respiratory support, and not a lot of them end up leading to be on your conventional mechanical ventilation. And the chance of them developing chronic lung disease was at 52%, and injury to the bowel with possible surgical intervention, you can see there, that's 48%, and sepsis, 48%, and the bleeds in the brain, and your severe ones, which is grade 3 and grade 4, was around 13%. And the chance of developing injury to damage to the white matter, which we also call periventricular leukomalacia, was around 7%. And the biggest concern you can see is growth failure. And remember, these babies, when they don't grow, the biggest concern is brain development. We end up with microcephaly, and there's 60% chance of neurodevelopmental impairment in these babies that are failing to thrive. And there's a 20% chance of also developing CP, just from growth failure. So they did a survey at these two centers. they asked a group of neonatologists to say at what gestation would they resuscitate the baby. So 11% of neonatologists that were surveyed, they refused to resuscitate babies at 23 completed weeks. 67% of them said they will not resuscitate at 22 weeks. 91% refused to resuscitate at 21 weeks. And here the issue is really not whether a physician would reject a parental request to resuscitate, but what standard the physician should use to determine the cutoff in terms of where do we resuscitate, where do we start in terms of gestation. And in response to this question, this author says that if we only look at gestational age, your gestational age is really not accurate enough to serve as the standard estimate based on the last menstrual period or the first trimester uterine size. And we always out by around 2 weeks. We might be thinking that the baby is 22 weeks and we find that maybe it's 24 weeks. And these other authors as well, they say, even if we use the second trimester ultrasound, it's only accurate only to within 10 to 14 days. And further, if we simply accept the prevailing success rate as the lowest, most reach of possibility, we have a self-fulfilling prophecy, and under those conditions, improvement in survival will never be reached. These are the general guidelines regarding obstetric interventions for threatened and imminent periviable birth, according to whether the fetus is considered potentially viable and the parents' wishes for aggressive intervention. If you look at babies less than 24 weeks, 22 weeks to 23, 22 weeks and 6 days, and your 23 weekers, in terms of use of antenatal steroids, it's really not recommended to be giving antenatal steroids to moms who are less than 22 weeks. Should we be using tocolytic agents? It's also not recommended. Use of magnesium sulfate for neuroprotection, this is also not recommended at less than 22 weeks. Use of antibiotics for prolonged rupture of membranes, they say you should consider it if delivery is not imminent. Intrapartum antibiotics for group B strep prophylaxis is also not recommended at this gestation. And continuous intrapartum electronic fetal monitoring is also not recommended. Cesarean delivery for fetal indication at less than 22 weeks is not recommended. And aggressive newborn resuscitation is also not recommended. But if you look at from 22 weeks and 0 days to 6 days, the use of antenatal steroids, they say you should consider if delivery at or later than 23 weeks is anticipated. And tocolytic agents is not recommended unless concurrent with antenatal steroids. Use of Mexal for neuroprotection is also not recommended. Antibiotics for prolonged rupture of membranes, they say you should consider if delivery is not imminent. And intrapartum antibiotics for group B strep prophylaxis is not recommended. And continuous intrapartum electronic fetal monitoring is also not recommended. Cesarean delivery for fetal indication is not recommended. And aggressive newborn resuscitation, it's not recommended unless considered potentially viable based on individual circumstances. And your babies at 23 weeks, antenatal steroids, it's recommended to use. Tocolytic agents, they say you should consider at 23 weeks. Mexal for neuroprotection, it's recommended. Antibiotics for prolonged rupture of membranes, it's recommended if delivery is not imminent. Intrapartum antibiotics for group B strep prophylaxis, it's recommended. Continuous intrapartum electronic fetal monitoring, it's also recommended at 23 weeks. A cesarean delivery, it's also recommended. And aggressive newborn resuscitation, it's recommended unless the baby is considered non-viable based on individual circumstances. These are considerations in terms of counseling. It's a very slide, you can see generally it says providers should be aware of local standards. For example, in the hospital and regulations, stating here your state laws. As I've said, in South Africa, viability is around 28 weeks. That is around a kilo. And they say counseling should be personalized and in the best interests of the family and their child, considering aspects beyond the gestational age. Remember, these babies who are at risk of neurodevelopmental impairment and disability. Then they say written guidelines should be developed by obstetric and neonatal teams with input from other stakeholders, for example, ethicists, nursing administration, risk managers, and former NICU families. We should use protocols and checklists as adjuncts for proper counseling and not as a stand-alone tools. And obstetric and neonatal interventions, including newborn resuscitation. The institution should provide for regular multidisciplinary conferences and teaching sessions. And before and after counseling sessions, the obstetric and neonatal care providers should confer to avoid conflicting information. And it further says obstetric and neonatal care providers should meet the parents together if feasible, and post-counseling debriefing should occur to share and confirm the decisions, if any, and repeated counseling should occur as clinical circumstances change. And during counseling, what we should try to do is to provide counseling in the family's preferred language and use trained professional interpreter as needed, and use family interpreter only if the family makes such a request. And we should foster informed and collaborative decision-making in an open, transparent, and supportive atmosphere, and seek out the family's concerns and how we can help them. And the content of the counseling, really, we should individualize the information that we provide to the families based on the family preferences, wants, and needs. And some will want to receive the detailed statistics, whereas other family members will prefer hearing only the bigger picture. We should investigate how the family wants to be directed in their decision-making process. We should consider the use of decision aids and other materials, and recognize that the family wishes may be influenced by their cultural background, religious, and beliefs, or both. Specific information includes providing institutional data regarding survival and disability if available, otherwise share regional and national and other population-based outcomes, which unfortunately in this gestational period, we don't have much data locally. And we should provide information regarding available obstetric interventions, including their potential benefits and risks, provide information regarding possibility of survival and disability separately. And we should offer information regarding anticipated NICU care, provide more information about potential ICU stay according to family wishes, appearance of the baby at birth, NICU complications, family-centered care in NICU, and provision for breast milk, and so on. We should discuss options for comfort care and circumstances that might result in reconsideration of life-sustaining interventions, and inform the family that the baby's appearance at birth and APGAR scores are of limited prognostic value for survival and long-term morbidities. And we should state that the infants born at extreme low gestational age have a reduced survival and increased risk of adverse long-term outcomes. And information given to families should include what some children cannot do because of disabilities and what many can do. And we should mention adaptation and coping difficulties, the meaning of disability, and the effect on families should also be included. And offer the family time to think about the information provided and needed decisions if circumstances permit, and encourage an input and prospective parents in terms of support for the family. So it is only in those rare occasions where we know that antenatally there's anencephaly, Porter syndrome, sonototrophic dysplasia, or a neonatal delivery at less than 22 weeks of gestation, that maybe a physician should refuse a parental request to initiate resuscitation. Otherwise, in all other circumstances, if asked, it's recommended that we should resuscitate and evaluate later. That should be the norm. This is just related to how we manage these babies, both term and term. They say that in uncompromised babies at delivery, we should consider delaying cord clamping for at least 1 minute, commence resuscitation using room air. We should use pulse oximetry attached to the right breast. That way you'll get your preductal sets and or to the hand to guide use of oxygen. Babies of less than 28 weeks of gestation should be completely covered up to their necks in a food-graded plastic wrap and without drying them immediately after birth, and they should then be nursed under a radiant heater and stabilized. Attempts to aspirate meconium from the nose and the mouth of an unborn baby while the head is still on the perineum is not recommended. And IV adrenaline is what is recommended to be used and this happens in very few occasions. And we should use capnography in addition to clinical assessment to confirm placement of the tracheal tube. Therapeutic hypothermia, these are your near-term and term babies with encephalopathy, which is moderate, who've got HIE. So we should consider using therapeutic hypothermia. So our prime infants at the limit of viability raise difficult ethical, legal, and social and economic questions. And neonatologists attending a conference, when they were surveyed about the delivery room behavior and the approach taken by the selected countries was explored. And the consensus generally ranged from comfort care at 22 weeks to full resuscitation at 24 weeks. And it was clear that cultural, social, and legal factors had a considerable impact on decision-making processes. This is a survey that was published in Journal of Perinatology in 2008. You can see the heading there, nobody likes preemie babies, the relative value of patients' lives. So they did a survey of, I'm sorry, this is a very busy slide, a survey of around 500 clinicians, and then they give them a scenario of 8 patients, a 24-weeker, a term newborn baby, a 2-month-old, a 7-year-old, 14-year-old, 35-year-old, a 50-year-old, and an 80-year-old. And they said to them, if you were to resuscitate these patients, what will be the order of preference? And you can see that, and on the 2-month-old, the 7-year-olds, 14, 35, 50, and 80-year-old, these patients, all of them had some degree of disability. But when they were asked on who will take priority, you can see a majority of them said the 7-year-old will be the first one, followed by the 2-month-old, 14-year-old, 35-year-old, the 50-year-old, and the 80-year-old and the 24-weeker. You can see that these were the last in terms of priority. So I think it just shows, if you go back to the slides, in conclusion, they say the order of resuscitation was not closely related to the predicted survival and impairment or potential life years gained. And the age appeared to have a strong influence, with children's lives being valued more than the adults. And this tendency was reversed for the newborn infants, who were undervalued compared with the older children, and most particularly for the premature baby. So you can see people's views about prem babies, and without much of evidence. This 624-week, around 600 gram, people said no. 35% of them said no, they will give the baby a chance. A majority prioritized these other age groups, even though there was already disability on those patients. So thank you very much. I think we'll give it a chance for questions if there's any.
Thank you so very much. Correct, Doc. That's actually a very fascinating topic because, as you said, in private, there's no real protocols as to what happens, and you'll find that all age groups, all gestational ages end up being resuscitated with active resuscitation from 20 weeks to 22 to 23. But when it comes to the counseling of patients, and I think this is actually a very important question, because we have such fragmentation of care in the private healthcare sector, and you don't always necessarily have multidisciplinary teams. Who usually leads this counseling for the parents in terms of the prognosis and the viability?
Usually, because remember these patients, they are seen by the obstetricians. They are the ones who will initiate the counseling, and particularly in the mothers who've got poor obstetric history. For example, if you've got a mother who has lost 4 or 5 babies, has got no live baby, maybe she's 23, 24 weeks. That's where maybe a pediatrician or a neonatologist get involved, invited by the gynecologist. But the recommendation is that we should cancel these families together. Maybe we should meet first and then agree on what we will be telling them. And we need to try and be honest with them. And I must say that, to be honest with you, with my little bit of experience, we are not that great in terms of doing counseling on these patients. And this is quite important because that will guide them in terms of what decision they are going to take. Because ultimately, at your 23, 24 weeks, they need to be educated, they need to be given information, including statistics on survival, and so that we help them in deciding on whether they would want to go ahead or with the delivery, or they would prefer to terminate the pregnancy.
Yeah, no. Especially so true about we're not all that great in counseling. So here we've got a question here that says from Dr. Clyde Green Thompson that says, when it comes to the topic of the resuscitation in this gestational age, who would initiate that discussion from the healthcare team?
The issue of resuscitation obviously will belong to the pediatrician or the neonatologist that is involved in the care of the patient. Look, what they do, for example, in the developed countries, if around 24 weeks, there's an agreement that you should go all the way. So in terms of resuscitating, but when you go to lower than that, like your 23 weekers, the recommendation there is that you need to be guided by the family. Obviously, during the time of delivery, the parents are invited, the father will be there. As soon as the baby is born, depending on how the baby looks like, for example, at 23 weeks, they will be there, and then you will be resuscitating and then also consulting them to decide on whether you should continue with the resuscitation, or if the baby is not doing it, whether to stop or not. It really just depends on the gestation of the patient.
All right. We've got a question here from patients that says, is there a national register to capture the preemies born in this country that will help to determine how SA is doing with these preemies in both private and state sector?
Look, I'm not sure if there's a register, to be honest with you. Maybe other people who are attending can respond to it. The problem is that, as I've said, this category of your 22 weekers to 25 weekers and 6 days, we tend to see more of these patients in the private sector. I think they see less of those in the state facilities, because there's clear guidelines looking at the state laws to say viability is a kilo. And I think at the moment, they would give a chance to babies who are around 700, 750 grams. Those who are less than that, your 24 weekers, I don't think they go aggressive on them. I might be wrong. We tend to go in private, even the gestation below that, your 23, 24 weekers. So we don't have national registry, to be honest. At the moment, it's individualized. Everyone does as they wish. There's no real guidelines that are developed. Maybe I think using the associations, maybe your SASOC and with your PMG, looking at also government guidelines. Maybe we should look into developing protocols on what should be the cutoff, how we should manage these patients, and also including counseling for the families.
Thank you. That actually leads into Abigail's question, because she wants your opinion as to what do you think the barriers and challenges are within the private healthcare industry for establishing these protocols and these cutoffs when it comes to extreme low birth weight babies. I think she wants your personal opinion on what do you think is stopping us in private healthcare from doing this.
Look, private healthcare is fragmented. We work as individuals. We not as a united team. And to be honest with you, I think maybe people are looking at what the state laws say. I mean, in South Africa, if they tell you viability is a kilo, any baby who's less than, for example, let me say less than 750 is not viable. A lot of people are really not interested in looking after those patients. Some pediatricians will even refuse to go to theater because they don't want to be involved in looking after 24, 25 weeker patients, or they would refer them to colleagues who have shown to have a better outcomes on those patients. So as I'm saying, maybe we should be using the associations, the pediatric association and the SASOC. Maybe we should look at getting back together, forming a committee, looking at guidelines to say what should be the cutoff, and stop doing whatever we want to do on these patients.
Yeah, no, that has been echoed by Dr. Green Thompson, who said that it's now become the norm within the private healthcare industry to continue with the escalated level of care in these young ones, in the 24 weekers and below, and to continue doing that. So far, I think that's it for today. Thank you. Here's one. From Vuyani. He says, in your experience, how is it, how are your outcomes in terms of preemies with the extreme low birth weights? And do you have any good practice suggestions that you might be able to give people for to make improvements in how they operate in their own practice?
Look, I've had an opportunity of working at Dr. S.K. Matseke and the old Netcare Clinton Hospital, and I've had a chance of looking after lots and lots of these tiny babies. To be honest with you, we had, in the last 10 years of my involvement in private practice, I had one 22-weeker who was born at 485 grams. And remember the gestations, you might think is a 22-weeker, and this baby is 24 weeks. So that baby survived and is a little bit delayed in terms of development. Your 500 grammars, we have had lots and lots of them that survived. But the other challenge there is also neurodevelopmental delay, where some of them will start walking at around 2 years. And then your 600 grammars, with my experience, they do quite well. But the challenge is on your 400 and your 500 grammars, to be honest with you. The way when the gynaes invite me, when we've got a mother who's around 23, 24 weeks, I insist on antenatal steroids. If you don't give steroids on those patients, I don't want to be involved, to be honest with you. And you can't give steroids now and then in an hour's time, you want us to deliver, that baby will not survive. I usually prefer that because they know these patients, these high-risk patients, there must be time for steroids. They give antenatal steroids. We wait at least for 72 hours or more. And then I've seen that if you do it that way, the chance of survival in those babies is quite increased. And if you don't do that, you deliver these moms and there hasn't been chance of steroids, the chance of bleeding, NEC, sepsis, in those, on those kids and renal failure is quite high. So I usually decide on which babies I get involved in. And my recommendation, to be honest with you, is maybe we should also look at how they do it in the developed countries. Maybe looking more at your 24-weekers plus, provided there's been a chance for steroids given to those patients, because your 600 grammars, the chance of survival is quite high. Your 23-weekers, you're going to run. I can tell you, they'll make you run and then you end up losing them.
Yeah.
And managing them, I think it's a different topic on how these babies must be managed. It's a different talk on its own. We're not really talking about how you manage fluids, nutrition, antibiotic use in them and all that. It's a different topic on its own on how to manage these babies.
So true. I've got who's here? I think we've got one Pongile here has just informed us that her child is a 25-weeker who has just turned 21 years old, who is turning 21 in October. So looks like we have a good outcome here. I myself had a 900 grammer who will be 19 this year. So in private, as you said, the outcomes are there. But so far tonight, Dr. Mnisi, thank you very much for opening us up for the year. I must say this is a very fascinating and informative topic. Many of our audience have also noted that. And I want to thank you for coming through tonight and giving us such invaluable information. And I hope this also urges the healthcare providers that we have here tonight to work together with one another and do the actual counseling of parents and empowering parents with the correct information and the outcomes and the prognosis. And I think once we start working together again in private, we'll be able to improve the outcomes that we get and do better by our patients and their parents. So, but I'd like to thank you for coming through tonight. And I would like to thank everyone this evening for joining us. And we'll see everybody next week with our topic for next week. Thank you, everyone, and good night.